All right, so for how many second years are in here? Y'all did everybody do preceptorship? A lot of y'all did, huh? I know I see some familiar faces. Who's really interested in going into emergency medicine in here? I know you are. Kind of, sort of, first years don't know for sure yet. So we're going to talk a little bit about the organizations of emergency medicine and why it's important for med students to get involved. And so I'll tell you a little about myself real quick, just so you know who's talking to you. I'm Dr. Piel. I've been here for 16 years. I finished my residency in Jackson, Mississippi in 2001. And so I started here in July of 2001, and I've been here ever since. So I did a 4-year residency in emergency medicine. That was kind of nice because the last year I didn't have to work that many shifts, but I moonlighted a ton. And so when I did come back and work shifts in the ER, I really knew what I needed to concentrate on. Because I've been on my own, you know, kind of learning those areas where there may be gaps in my knowledge or questions. So that was good. Before that, I went to medical school here, but it was a lot different than it is now. I want to go back to med school now because these facilities are all so nice. Anyway, when Ryan finishes, he's going to pay for me to go back to med school. So anyway, so that's basically that. What else? That's pretty much all I want to say about that. So the main organization with emergency medicine is the American College of Emergency Physicians, okay, ASEP. And ASEP's been around a long time. So does anybody know when emergency medicine started as a specialty? It's one of the newer ones out there. Does anybody know? I don't know if anyone was alive in this room at that time other than me and this nice gentleman right back here. So emergency medicine became a specialty in '79, okay? Was anybody alive in '79? When were y'all born?
91.
Oh my God. So anyway, '79 it became a specialty, but ASEP actually formed in '68. So it started long before the American Board of Medical Specialties kind of allowed emergency medicine to sit at the table because there's a lot to get together and be allowed to do that. Before that, emergency departments were run by, there weren't any basically. You waited till Monday, or you know there was a nurse in the emergency room and they would tell you to take 2 aspirin and call your doctor in the morning. And then when emergency medicine did kind of start, or emergency rooms did start, they just kind of put a little area in the basement that might have a few beds in it or whatever, just to deal with like extreme things in the middle of the night. But you may not be taken care of by a physician even then. And then when they did kind of designate an emergency department, then whoever was on call or whoever was picked on the hospital staff to run the place ran the place for that weekend or that day. So like you may be on staff there and you had to take 3 days call in the emergency room, so you had to work a shift down there. You may be a dermatologist or a psychiatrist or something. So it was good if you came in and you had a dermatologic problem, but if you had something else, you were in trouble. And so it was recognized pretty early that emergency medicine should probably be a specialty. So ASEP has been around, So ASEP's been around for a while now. And we are part of the American Board of Medical Specialties, obviously. TCEP is our state chapter for emergency medicine. So there's 53 chapters of emergency medicine under ASEP. There's only 50 states, obviously. So DC has a chapter, and then there's a government chapter, I think, for military stuff, and then Puerto Rico has a chapter. So there's 53 chapters of emergency medicine, and they're all under ASEP. And then we have the Emergency Medicine Residents Association, which is its own individual organization. We'll talk a little bit about that more. So the mission statement for ASEP is basically, it's there to help provide quality care, number one, and then basically to advocate for emergency physicians. And they throw patients and the public in there too, but they're basically our national organization to help fight for what we think is important in emergency medicine, okay? And to make sure that we're providing quality care. And they represent us nationally. There's a political action committee and all associated with ASEP, and then they work with the AMA, being a boarded specialty to try to advocate for emergency medicine, okay? So that's ASEP. TCEP, very similar to ASEP in the mission statement. In fact, it's like they basically copy things. It's basically quality emergency care, and they represent us at the state level. And some of you guys have probably been to TCEP's conference before, correct? Yeah, so they basically advocate for emergency medicine at the state level, and then they work with state political action committees and TMA. okay, Texas Medical Association. And whenever you are a member of ASEP, you are a member of your state chapter too. So when I was in Mississippi as a resident there, when I paid my dues to ASEP, I automatically was part of the Mississippi College of Emergency Physicians. Tell you a quick story. When I came back to Texas, one time the dues are pretty expensive for ASEP for physicians, obviously, because they need a significant amount of money to function. And they're headquartered in Dallas. Have y'all ever been to, anybody ever been by the ASEP headquarters? They're pretty nice. They're in Las Colinas. They used to be in another building in that area, but they built their own facility. And so it's really a pretty state-of-the-art facility. But anyway, I tried to pay my dues without paying my chapter dues. I just kind of crossed through them. And they sent it back to me and said, yeah, you can't be a member of ASEP without being a chapter member too. So anyway. Now EMRE is its own organization. Okay, they're not really part of ASEP and they're not necessarily under ASEP, but they work closely with ASEP, okay? So their mission statement is basically to kind of promote education and to support the emergency medicine resident, okay? And so anyone, when y'all were working, y'all work with Chad Krause some? Anybody know Chad Krause? When y'all did your preceptorship, somebody worked with Chad? Chad was an officer in the Emergency Medicine Resident Association, so he worked some part-time with us, particularly during the summer and last spring, so I thought maybe you guys could work with him some. But they're basically there to represent residents. They work closely with ASEP, and so they don't have a lot of political involvement, and not necessarily that they need one, or need any, but it is the only independent resident group. So that's kind of cool. EMRE put out a video called 24/7/365. Has anyone have y'all ever seen it? No one's seen 24/7/365? You've seen it? It's a pretty good video. You should watch that sometime. I mean, I know you guys are studying all the time, but it's like a 1-hour video, but it'll tell you all about the history of emergency medicine. And Chad Krause was actually one of the officers in EMRE when they made that video, and they went around and basically interviewed all the people who got together, even back in '68, to help form ASEP and then advocate for emergency medicine and get us, to be part of the American Board of Medical Specialties. And so that's pretty cool. A lot of people in the video are dead now because they were older even when they did it. They really did it at a really opportune time. But a lot of the leaders who are still there are in that video. And you'll see these people at national conferences still, and they'll be lecturing. And if you do, like I did the Emergency Medicine Directors Academy in Dallas, and a lot of those people lecture there, so you get to know some of the people, the figureheads in emergency medicine. It's kind of neat. It's a small community of physicians. But anyway, EMRE is a neat organization, and that video is awesome just to, sit down and watch it. You can just Google 24/7/365, like evolution of emergency medicine, but it's on the EMRE website. You can play it. You don't have to buy it or anything like that. So what's in it for med students? Why be a part of these things for you guys? Hopefully there's some benefits. You can say on your CV, obviously, that you're a member of ASEP. I looked at my membership card. I should have brought it in my wallet. But anyway, I've been a member since February of 1996. I was in my 3rd year of med school at that point in time. What were you doing in 1996? 2 years old? Yeah, 2 years old. Yeah. So anyway, I guess I joined my 3rd year. There's no reason I shouldn't have maybe joined earlier. I knew I probably wanted to go into emergency medicine. But once you join, you're going to start getting emails from these people, and you'll have access to all the things that those members have. And so it's kind of neat. Your standard letter of recommendation, you know what that is, maybe not. But when you apply for emergency medicine residency, you have to complete a standard letter of recommendation. And I can't write it for you. I used to write them, but several years ago, they said, hey, these letters have to come out of an emergency medicine training program. And so until we get a training program here at UMC, we can't write these things. So they have to be written by them. But there's an area on the SLOR, standard letter of rec, that kind of talks about your commitment to emergency medicine. I think there's a picture of it coming up. But they'll give you lots of information about the specialty, both clinical and non-clinical, just things that are affecting you in emergency medicine. You'll get to know the program directors, the future employers, everything like that, from a national level and a state level. But this is what's on the standard letter of rec. They're going to ask you what's your commitment to emergency medicine. And I'm gonna be like, yeah, this guy's good, he's top 10%, and no, he's not a member of anything, he hasn't been involved in anything that's lower third. No one will hopefully put that down for you, but anyway. So there are a lot of benefits. You'll basically get, all their information, you'll automatically get their journals. EMRE, you'll be a member of all this together, so EMRE will send you their information, TCEP will send you their information, so it is important to be involved. Let me go through this whole slide. There are some awards as well. Basically, the ASEP weekend reviews and daily briefings are just emails. Like right before I came in here today, this morning, ASEP sent out an email, and it had, it had like 4 different things. It was talking about emergency department visits are going to top like 150 million in 2016 or something like that. So basically, that's like every person in the United States goes to the emergency room once every 2.5 years. What else was there an article about? What else did I look at actually? I'm blank on it right now. But they gave like 4 different articles. They were kind of interesting. Some of them you just breeze over and they don't seem very important to you. Some of them are somewhat interesting. So if you're interested in emergency medicine, you'll find some good things in there. And it'll be a break from studying all the time anyway. So they do have some awards that you can apply for. And obviously, as you're going forward, if you're applying to an emergency medicine residency, that would look good if you did have an award. And if you are involved in research at this level, it's not a must to do that. But emergency medicine is obviously competitive, so if you're looking at a really competitive program, especially one that's research oriented, it's not a bad idea. So if you want to fund your own project, they have resources for that, both at the national and the state level. And then lots of books and journals. Our main journal, I think, there is Annals of Emergency Medicine, and so you'll get that. They have podcasts, textbook discounts, so if you buy emergency medicine texts and all that, not that you're going to buy that stuff yet. Our big meetings are Scientific Assembly, which is going on later this month in Washington, D.C. Is anyone going? You're not going to ASEP, were you? ASEP's pretty neat. And the first time I went, I was probably in my 3rd year of residency, and it's really an amazing venue. It's nice to be in a place where you're surrounded by people that do exactly what you do, and understand what your problems are and what you're going through. And so it's really a neat conference. And you sign up for things well in advance. So you can sign up for things that you're interested in. They have skills labs, all sorts of stuff. So really ASEP is a neat venue. There's also a leadership and advocacy council that's big within ASEP, and you can be a part of that. There's a lot of different sections. Cruise ship medicine for bird, there, go on a cruise ship. Disaster medicine, sports medicine. Some people that in emergency medicine have gone on cruise ship medicine thinking they wouldn't have to pay any taxes, because you're floating out in international waters most of the time, but that's not true. You have to pay taxes on that money. So just be aware of that. There's 26 committees within ASEP, and those committees are, there's everything. You can go to the website and look at it, but they'll have wilderness medicine stuff, rural emergency medicine stuff, all sorts of toxicology type stuff, because that's a subspecialty, EMS things. So in all these committees, they accept 2 medical students, I think, to be members of these committees as well. So you can always do that. What else did I miss there? I think that's it. What was that last bullet point? Anyway, it just kind of goes away. This is an advertisement for Scientific Assembly, obviously when it was Vegas, because there's some poker chips up here at Mandalay Bay actually. This year it's in Washington, D.C. Leadership and Advocacy Conference moves around too. I think last year it was in Dallas. But anyway, large gathering of emergency medicine physicians, that's what is there. Academic affairs, disaster preparedness, EMS, medical legal stuff, pediatric emergency medicine, public health, lots of different committees. So, and as med students, you can be part of those. And I think everyone gets to be a part of one section as well. If you want to be a part of multiple sections, I think you have to pay certain fees, but everybody can be a member of one section. So if there's one section you think, oh, I'm interested in that, then you can go to those section meetings at ASEP, and some of those start even before the conference actually starts. So you can fly in a little bit early to Vegas, do a little gambling, and go to your section meeting, if it's in Vegas. TCEP has a newsletter called Emphasis, and again, all this stuff is going to be more at the state level instead of at the national level. And so that's what emphasis is, and you'll get that in the mail. And whatever state you're in, they'll have a similar chapter or organization. The TCEP annual meeting is really important for you guys because they have resident fairs there. And so if you're interested in staying in Texas, obviously, all the residency program directors are going to be there at that meeting. So you can rub shoulders with those people. Some of them you may be doing rotations with, and they'll be glad to see you, and they'll see your face again and be like, hey, yeah, this guy's really involved. And so I think that's important too. What else about TCEP? You went.
Yeah, we're going again this year. It's in Houston this year. So, but yeah, you get to, there's a medical student track day where it's just all medical students in emergency medicine, and you get to meet program directors. They talk about different pathways through emergency medicine, things like that. So it's really informative. We'll be going over it more later.
Yeah, that's
this
cool.
year because it's in April.
So if you can go, I mean, I think that's a good thing to do. ASEP has some similar things at the national level. They'll have some medical student conferences and places where you can go and meet some residency program directors, but it's just on a larger scale. So I think the TCEP thing is probably better for that actually. As you become an emergency medicine resident and you go to ASEP, if you're looking for jobs, they have job fairs and things like that. So you can go to the job fair and they'll have people, man, from all over the United States advertising what jobs they have available in emergency medicine. They can tell you a little bit about them and all that stuff. So anyway, membership. Again, EMRE is the Emergency Medicine Residents Association, its own individual organization. And so they have their own newsletter and all. They have several podcasts. Some of those podcasts have to do with interviewing and things for residency. Those can be very beneficial, obviously, to you guys as med students. And then they have some awards that you can apply for and research grants if you're interested in that. That would be, I mean, that's amazing. If someone went and got a research grant on one of these, my hat's off to you for doing that. I think if you did get involved in research, it's not even necessary to do that much as long as you're involved peripherally. You're probably really doing more than the average applicant is doing, so that's awesome. But if research is your background and you're already doing it and you wanted to apply for a grant, they have that available. Travel scholarships and all. I think the big thing about, they have their own publication too. I think the big thing about EMRE is that they're just going to send you tons of reference guides, and not that it's going to be that important to you while you're in med school. Let me pull them up here. Everything is a click on this presentation. But anyway, like the antibiotic guide, I remember getting that and sticking it in my pocket and using it even in like a fourth year med school, because you'll get that. And they have a lot of other handy pocket cards that when you need your peripheral brain and you're kind of learning stuff, it's handy to have. I think that was probably the most important thing I got out of EMRE as a medical student. And then as a resident, you know, a lot of their stuff is certainly more applicable to actually being a resident and their advocacy for residents. And so I think that's good. Again, you'll get discounts on textbooks through them and also through ASEP themselves. The ASEP book has almost anything you could want, and being a member, you're going to get discounts there. So I guess they have 5 committees as well. They have a medical student governing council. So if you're a member of these things, you can look into all that and see what applies to me. What do I want to be a part of? Okay. The more you're involved in, I think it's probably better. So even though we talked about 3 different organizations, when you join them, you're a part of this as a medical student or a resident. You're a part of all of them for one price. Okay. And I'm not here to. I don't get anything out of this, so it doesn't necessarily matter to me. But they say that you get about $252 worth of stuff for $55 a year, and that's your cost as a medical student to be part of ASEP, TCEP, and then they automatically get you into Emergency Medicine Residents Association to EMRE. And so you can join all 3 by either going to the ASEP website, the EMRE website, any of those places you can go to, and you can join all 3. What's in it for us? Basically, a lot of networking for you guys. You guys live in the social media era, okay? I was a 3rd year in residency before I got a cell phone, and I got one cell phone from my wife and I. And so you guys live in this era of social media, so social networking for you guys is huge. And so I think that's probably the biggest benefit now. And you'll meet a lot of the leaders. There's leadership opportunity for everyone in this room, obviously, by being in those organizations. And you can see what else is out there, job-wise, committee-wise, whatever you're interested in. there's something out there for you in these organizations. So I certainly advocate for being a part of them. I mentioned I've been a member since '96, and then once you finish fellowship, or once you finish residency training, you can become a fellow of the American College of Emergency Physicians, and I became a fellow in '03. So you have to finish your residency, and then you have to practice, I think, 2 years. You have to pass your board exams, and you have to be involved in certain things, like so many hospital committees at the local level, and do some other things. And once you do that, you become a fellow, and then they have a ceremony at ASEP. So you can go to that, and they'll have a fellow convocation ceremony, and you go through and become a fellow. So that's a big deal too. So this code doesn't have it, but if you see, most emergency physicians put that they're a fellow, FACEP fellow of the American College of Emergency Physicians. This is really the organization that got us where we are. So anyway, what other questions do you have? It doesn't even have to be about this. It can be about emergency medicine in general, anything you're wondering about. I'm open for anything.
When are y'all in the residency?
I don't know. Man, we've got the pieces in place finally, and I met with Varma and J. Edward Bates probably 2 months ago, and I'm in a holding pattern of, they're supposed to set up a meeting with Mark Bundenberg and David Allison, and Mark Bundenberg's going to take over as CEO of the hospital. But they're supposed to set up a meeting now, and we're supposed to talk about the funding. Because all we lack is the funding. J. Edward Bates thinks we probably have enough, there's enough grants out there. I was talking earlier to these other guys, but there's enough grant money out there where we could probably float the first 2 years of the program. By the third year, when we have a full complement of residents, I can probably fund the residency off the savings of just having residents in the ER. So, yeah. We'll have to.
With the cruise ship medicine,
Yeah.
is that like a fellowship or?
No. It's just that once you, I mean, emergency physicians are great for cruise ship medicine because that's what, I mean, the great thing about emergency medicine is you can deal with pretty much anything. So if you go into pediatrics, you train in pediatrics, but you don't know diddly about myocardial infarctions or traumas or anything else, stroke care. And so basically, the standard of care and can take care of and stabilize anything. And so for cruise ship medicine, it's perfect. So you just, you go to work on a cruise ship. It seems very glamorous, but I've heard from people it's really not all that great of a gig. Yeah. I mean, a lot of people did. They think, man, I'm going to escape paying taxes because I'm making money on the, international water. They can't tax me for that, but they actually do. So those are the things I've heard. I really don't know anything about it. It sounds glamorous to me too. Man, I watch Lubbock. I think, yeah.
What are some of the biggest negatives about EM?
We never close. It's 24/7, 365, and someone works Christmas Day, Thanksgiving, 4th of July. Somebody's in that ER all the time. I think that's the biggest negative. Whereas most people who go into some other practice, they may still be on call that day, but they're going to rev down their practice. They're not going to schedule, operations or clinic or procedures or anything that day. So, and even though they're on call, they can still enjoy some time away. So being on call versus working a shift in emergency medicine are two different things. When you're working a shift, you're busy, you're there all the time thinking and engaged. And so, when you're on call, you have some downtime too. So I think that's probably the biggest thing. I think the other negative, and I don't know that it's a negative yet, but I'm getting older. So I'm wondering, am I going to be able to do this in 15 years? I'm going to be already old, and so I'm feeling the rigors of it. But I think there's always a place for it. There's tons of opportunity in emergency medicine. You can do rural things. Like a lot of young people don't want to work in rural areas. And so you can still work in a rural area or, a clinic type situation. Most of us are too type A personality to do that probably, but I think there's other things you can transition into. Burnout you would hear is high for emergency medicine, and that's probably true if you work in a real busy place. So it's up to you to find a job that doesn't just run you ragged. And that's probably true of whatever you go into. If you're the shiznit surgeon and you go into some place and they're going to run you ragged, you're going to burn out. So it's up to you to choose a job where you have a balance of, family, your job, whatever you like to do, your interests, then I think you're probably pretty safe. Those are probably the negatives. The good thing is that you do get to go home every night and sleep in your bed, or every day. You do get to go home some every day. And when you do go home, you can turn it off and forget about it pretty much. I think that's probably the biggest thing. Compensation's good. I think that's a positive. What else, Ryan? Good play. It's a great specialty, though, no doubt. I saw anybody else? Somebody else had a question. Yes, sir.
What's the residency like?
So there's certain required things in a residency. So the first year, like I did a 4-year residency, and so the Residency Review Committee for Emergency Medicine, all the CORD or whatever they're called, they come up with a guideline. So you have to do so much pediatrics, so many critical care months, so much trauma, ortho, everything else. So they kind of delineate that. So you do most of that within the first 18 months or so of your residency. So the first year of my residency, I was in the emergency department 2 months, once in the PD ER, once in the adult ER. And the rest of the time I was doing medicine months or ICU months or pediatrics. I'm trying to think what else we did. But anyway, first year, mostly out of the ER. Second year, more in the emergency room, but I still had probably 6 months of outside rotations. So I know we did pediatric ICU second year, probably did, what else did we do? There were several outside rotations second year, but again, probably 6 months plus of ER second year. Third year was almost entirely emergency medicine, with maybe toxicology and ultrasound being the off months. But I didn't have to go do anything outside of the ER unless it was elective. So if you want to do cardiology or derm or something like that, you would have an elective rotation. Usually those are two weeks at a time, not a whole month. And then the last year's all, for me, 4-year residency, last year was all in the ER. So, and then as a chief, you didn't have to work. You had to work. You had to do a lot of lectures. You had to do a lot of conference, and so that took some of your time. But you have to look at moonlighting too. Moonlighting makes it tolerable because you guys know right now you're going to school and you're not making any money. I doubt anybody in there has a job. Yeah. So moonlighting is just working, as an emergency physician, working in an ER somewhere. And so, like when I was in Mississippi's kind of like Lubbock. There's a lot of rural areas and small towns around there. And so, like I moonlighted a lot in Vicksburg and Meridian, Mississippi, and there were towns all over there. So you would just work on your own in those towns, and you get paid pretty well as opposed to being a residency or a resident. So resident salary right now, I don't know, is maybe 40,000, 55,000 a year. Jesus Christ, I'm paying $55,000 a year. So, but when you moonlight, I don't know, you'll make. Like when I moonlighted, we'd make $100 an hour probably, and now it's probably closer to $200 an hour. So you go work 12 hours and make some money. The only bad thing is your name's on the bottom of that chart, so you realize real quick where you're deficient and what you're good at. So, and it depends on how large the place is. Like here, some of the family medicine people moonlight places where there's not going to be many people walking anyway, so you're pretty safe. But anything at any time, you better be ready to take care of it, because your name's on the bottom of the chart. So that's what moonlighting is. And some residency programs are kind of anti-moonlighting, some are okay with it. So you have to, when you're doing interviews, find out about how the policy is, and you'll talk to the residents too, and you'll know what they do. Where I was, you had to have a 1.5 years under your belt, so you couldn't moonlight until Christmas of your second year, because they didn't want to put someone out there that didn't have any experience in the ER at all. So, anyway. Yes, sir.
What's your opinion on 3-year residencies versus 4 years?
4 years are better. Yeah. I don't know. I think that the only reason a lot of places started out as 4 years and then there was a lot of mix. The program I went to was really a 2, 3, 4 program. So it wasn't even, but I was one of they had 6 spots or so that matched into the first transitional year 2 that they set up. So I matched into that position, so I did all 4 years there. and the emergency medicine people kind of controlled what we did during that first year. So we got a lot of our stuff out of the way. I mean, it's basically like I said, the fourth year was kind of nice because I was actually moonlighting a ton, and I realized where my deficiencies were. So when I went back and worked the shift, I knew what I needed to ask the attendings, what I needed to concentrate on. And so it's just more experience. But 3 years is, I think, plenty. I mean, you're going to pass them more than you can. And the government only, you know, the government helps offset the cost of some of those residencies that have been established for a long time. They only say they're paying for 3 years, so that's it. Yes.
How has practicing emergency medicine changed since you began? Do you see any new challenges emerging in the future?
That's a good question. It has. There's no doubt it's changed. I think the biggest change initially was the electronic record. We had an electronic record when I left my residency in '01, but it was really rudimentary. It wasn't good. You couldn't import the labs or anything. I mean, it was very cumbersome. And so when I came back here, we were on paper charts again, and that was kind of easy. But paper charts are a pain in the butt because you go into a chart and you want to go look at an old EKG or something. We had to order the medical records from downstairs and wait for them to come up before I could compare that EKG. You know, and at that time too, no X-rays were electronic. So when I went to med school, your job as a med student was to carry the X-rays around. So you always had this stack of X-rays you were carrying around, and you had to go get them ready in the morning. You go around and you had to go down to the X-ray department, the file room, and request all these films, so that you had that daily chest X-ray and all on that patient. You carried them around, and there was only one copy, so you better not lose it. And then they asked for that. Hey, where's the X-ray? That was part of being a good med student. So now it's all on the computer. So man, the computer thing has changed tremendously. I think it's changed medicine tremendously. The same with information. I mean, when I started, you know, even residents here, like when you used to, residents walk around, their pockets were full of material, man, full of books and stuff. And now you don't have to do that because you can pull your phone out and Google something if you need to. And so you can see what the dose of a medicine is or something like that. That wasn't available a long time ago. So you either had to know the dose or have it on a reference card somewhere so you could figure out what to do. So, and now all that stuff's on your phone. So that's changed a lot. The practice of taking care of patients hasn't changed any. I don't think it's still the same. Certainly the way we do things changes. So the way we take care of stroke patients and all changes. You know, we do things totally different there than we used to do. Same with MIs, lab testing, things we have available now to test for myocardial ischemia and blood clot breakdown. Things is totally different than what we had 15 years ago. So in that part, it's better. It's gotten better, easier, I think. Used to, when you came in and you needed a CT for an appendix, man, you debated whether you needed to do it or not. Now you just do it. Now the surgeon wants it done. But back then, it was a big resource to send a patient over to the CAT scan and get a CAT scan. So you really put a lot of thought into whether you do it. And now that technology is readily available, it takes that long to scan. The scanners are super fast. So in those days, it was slower.
What about any challenges that have emerged? Anything that's difficult or that you see becoming difficult?
I don't know. I think patients complain more. You know, we live in a this fast food society or whatever, where people want instant this and that gratification and everything, and so nobody wants to wait. No one's happy. I don't know. It's harder to make people happy than it used to be, and that's changed a little bit. That seems somewhat challenging. It's challenging to get nursing to do their job because they're all looking at Facebook. I talked to my wife about that yesterday. I was like, you know, I wish we didn't have cell phones anymore, so nurses would go to work and do their job. And I go by the nursing station, everybody's on their cell phone, and they're not paying attention to patient care. That bothers me. And the reason is because technology slipped in without any regulation at all. Because I can assure you, if you would have walked into a nursing station and some nurse would have had some computer that they brought from home open with some crap on it, well, the supervisor would have kicked their tail. Now it's everybody's got their phone and I think that's dangerous, but man, that's certainly different. I think the benefits of technology certainly outweigh the bad things. I don't know, other challenges, I think otherwise it's gotten better. You know, ASEP, like ASEP's advocacy has made it a lot easier. You know, early on in emergency medicine, there was patient dumping and stuff. So if someone came here and you didn't want to take care of that patient, you just said, no, we're not accepting them. Well, now that's against the law. You can't do that. So some things have made it better. So, but that's a good question. I think it's just trying to take care of ever increasing volumes and be more efficient at what we do, because more and more people seek care in the emergency room. So yeah.
I know you see like some other specialties in the ER now, like family medicine.
Yeah.
What would outweigh, I guess, in choosing like if you're gonna do like family medicine process residency?
Yeah. Well, I mean, you should, if you want to do emergency medicine, you should do an emergency medicine residency.
Sure.
Or you won't have a job as a, or you'll be working in a very small volume ER.
Okay.
Because if you go to most large cities now, they won't hire you for family medicine. Even I won't hire you anymore. So you got to be board certified now. You need to be board certified. Or if you want to do family medicine and work in a small volume ER, that's fine. But if you really want to be an emergency medicine physician, do a residency. If you go to most places, we're pretty rural out here. So you see things out here you don't see somewhere else. But you go to Jackson, Mississippi, and try to apply for a job in an emergency room, and they look at you. Emergency medicine. Yeah.
That's not for like say someone who's old school family practice that's been doing ER for 30 years.
You're gonna get a job there. Yeah. No. It's a requirement. Yeah.
What options do you have, or have you seen anybody asking for EM doctors to work outside the U.S.? As in like mission trips or anything?
I've gone on mission trips before as a resident, not as an attending, but I don't know how to answer that question. I mean, the availability is there. I mean, any physician can certainly go on a mission trip, and again, emergency physicians are good for it too. But and the ones that I went on, we saw patients of all sorts, you know. And so the thing is, your resources are limited when you go on a mission trip, so it's not like you're going to be doing state-of-the-art emergency care there. You're going to be seeing patients sit at a cardboard table, you know, and you're going to have some drugs in hand. That's about it. It's still kind of cool. But... That question? All right. What else?
What's your schedule like?
My schedule? Right now I'm the medical director, so I work 8 shifts a month in the ER, and then I'll probably do another 80 to 90 hours of administrative work. So what is that? 12 times 8 is 96, and then 180 to 200 hours a month. So 40 to 45 hours a week. Most contract companies and most emergency groups want their people working about 12 shifts a month, 144 hours a month. Once you get over 160, burnout starts to become an issue. And so some contract companies won't let their physicians work over 160 because they know it's just too much. They'll get to you. That's 13 shifts a month. 56 would be good. Yes, sir.
Are most jobs like salary based or like
That's a good question. You know, emergency medicine is if you're in an academic institution, it'll be mostly salary based. If you are in a private institution, then it'll be like an hourly rate with some other benefits, like based on productivity, maybe things like that. Things that are important to the healthcare system, patient satisfaction, quality of care, whatever. A lot of emergency medicine has obviously gone to contract companies. It's kind of strange. Emergency medicine kind of started as its own specialty, and then they had their own groups of emergency physicians, and emergency physicians got tired of running their own groups because there were things involved in that. You know, there's legal things you have to deal with, and billing issues and everything. So then they went to work for contract companies like Team Health and EMRE and those types of places, so that they would take care of that, and all the physician had to do is show up for work and go home. Now the pendulum is swinging back to where physicians, like freestanding ERs, they want to do their own thing again. So they want to get involved with all that stuff again and do their own building and their own malpractice and their own landscaping and air conditioning contract work, I guess. I don't know. That to me is kind of odd, but yeah. The good thing is you don't have to worry about overhead. That's one nice thing about specialty. Someone said the benefits is I don't have to worry about setting up a practice. When I go to work, the nurses' salary, the nurses are paid for, all the equipment's there. I don't have to buy a CT scanner or anything else. So that's kind of nice. Yes,
You just mentioned the standalone ERs. What's your,
I think they should go away. Yeah. It's not good, it's not good public health. It's for-profit medicine. When you see them go up on the poor side of town or in rural areas, then I'll be an advocate for them. But until then, I'm not an advocate for that. That's not good emergency care. Yeah. You go in there with a heart attack, being a good emergency department is not just that ER itself. It's having an operating room you can go to, a cath lab you can go to, whatever. So you have a stroke and you go to one of those places and you just wasted a lot of time getting to the definitive care. So I don't think that's a good idea. Yes.
For the guys that moonlight, are they mostly EM residents, or do you see residents from other specialties?
You'll see other specialties, yeah. Like even here, I think there are a lot of the small towns that go work, like Crosbyton and all those little moonlight. Yeah. Yeah. I just hope they just hope that something comes in that they know about, I guess. Because some pregnant lady may walk in and you're going to be ready to take care of her, or whatever, baby, whatever. Anywho, and that's why emergency medicine became special. Take care of that stuff. What else, guys? I know y'all have one other thing y'all need to deal with. But I'm here, yeah.
How much is research, like, how important is research when applying to residency?
That's a good question.
Research do we do?
Man, I don't know. I don't know exactly how to answer that question.
Presentation.
Oh, there you go. I don't think it, personally, I don't think it's necessary to get into an EM residency to do research. I never did any, and I know I went in a long time ago, but even now, I think it's a feather in your cap if you have some involvement with research. I think it doesn't hurt you at all, but it's not a must either. Just like saying don't apply to emergency medicine unless you're in the top half of your class or something. Don't let that keep you from doing what you want to do. Just be strong in other areas and make sure you have a good application. You'll still get in. You'll be okay. But I think it's good to do research, and you'll have to do some when you're a resident. There's no doubt it's part of your training. You'll have to have a scholarly project and all. So it's certainly important once you get to that level. But you'll have research program directors there and everything to help you do that stuff. So, and I guess you'll talk about that next. But personally, I don't think it's a must, but I think it's a feather in your cap if you do. I mean, I think it's great. Don't let it consume you so that your grades start falling apart or something else important, man. So, yes, sir.
Besides stepping grades, what things do you think you should emphasize to?
To have a strong application. You want emergency medicine letters, so you don't think that a surgery letter or a family medicine letter or something else doesn't weigh very heavily. In fact, it might not even be read. I wouldn't read it. As a chief resident, I didn't read any letters if they weren't EM letters. Do well on the steps. A lot of times those are cutoffs. It's kind of like the MCAT. There has to be some cutoff for all the applications that come in, and so they'll use a certain board score as a cutoff. If you're a foreign medical grad, that score is even higher. And good emergency medicine letters are a benefit. If you really like a program, go do a rotation there so you get to know the people. Man, that's a shoe-in. If I have two guys and this guy looks great on paper, and this guy's mediocre, but he did a rotation with him, we really liked him, I'm going to take that guy over him because I already know what I'm getting. And so that's a plus. None of this stuff hurts you, man. I mean, being involved, and you could say, hey, man, I've been interested in the specialty, and I've been on a committee with ASEP for whatever, a couple of years, and I've gone to these conferences. Dude, that will blow them out of the water probably. Yeah. Good stuff. Yes. But other than that, I don't know. What do you think?
Another presentation?
Yeah, it's in the presentation. EMRE, EMRE, go on EMRE's deal if you're a part of that, because they have a podcast on that very thing, kind of strengthening your interview, I guess, your application. Yeah. What do y'all think? Yes,
So
ma'am.
for each kind of specialty, they talk about like this mold or like certain characteristics kind of
Yeah.
and a fit into a certain. So as far as like, what would you say are some characteristics that go on?
Attention deficit disorder. So we're kind of, I don't know, maybe high-strung, attention deficit. You know, people say you're adrenaline junkies, but if you're on internal medicine rotation and like 2 minutes into the interview, like we're done here, the diagnosis is made, what the hell are we still talking about? You're cut out for emergency medicine. It drove me nuts in med school. We'd be sitting there mentally masturbating over something. This is not that hard. You know? So we kind of like to move on, get, you know, next. It's not that we don't have any patients, it's just that we're, I don't know, maybe high-strung, high-energy people. If you like to really sit down and think things over, this is not your specialty. It's really quick decisions. And, probably high stress. If you like stress, this is your job. You're going to be crunched. Yeah.
Does it help to volunteer in the ER at all?
Yeah, I think they're going to ask you when you interview, hey, why do you want to do emergency medicine? And if you tell them, man, I think it's the coolest medicine in the world. But if you say, hey, I've spent this much time, I've considered that I thought I would like it, and I spent this much time in the emergency room. What I like about it, those guys, you know, they deal with the problem immediately and have a big impact on that patient's treatment. But I kind of like it better than following through the course of therapy or whatever. You have a reason for why you like it. I think that's important. So, yeah, spending time down there is going to help you answer those questions, feel those questions better. And the person that's talking to you is going to know immediately, oh man, this guy knows what he's talking about. You know, me, when I was in college, I worked in ER as a tech for a couple of years. Now we have some scribes too. The scribe thing is what it is. You get exposed to terminology and you get to see a lot of stuff. As a tech, I got to do a lot of stuff. I put on splints and I got to help the physician sew. I didn't get to sew, but we gloved up and cut sutures and we did all the procedures with them. So to me, that was more hands-on than being a scribe. I thought that was kind of cool to do splints and you actually get to do some stuff. But I think all the experience you can get will help you, yes. Whether it's volunteer work, working actually in an ER or whatever. I think community service is important too. I think that I really stress out with my kids nowadays. I'm like, man, get involved, do some other stuff. I think that really strengthens your education. If I'm looking at a young person, I see that they do what they do, but they're also giving something back to the community, and that's a plus. I think that's good. It's good for humanity. Yes.
As far as that community service goes, is it okay if it's not necessarily medicine related?
It doesn't have to be medicine related. Go work at a food bank. You know, whatever you do. Hey man, I give back to my community in some way that's unselfish. And I think that's a good thing. It doesn't have to be all the time, but sometimes. I spent Thanksgiving down giving meals at the homeless shelter. That's pretty cool, man. That's good stuff. That's an altruistic type thing, yeah. Good stuff. Because that's kind of what you do in emergency medicine. We're the only ones that don't ask for payment when you come see us. We take care of everybody. And that's a cool thing. Someone said, what's the benefit, especially? That's the benefit. Is that when someone comes in, I don't have to care whether they got money, who they are, what color they are, what their religion is. It doesn't really matter. All I care about is, hey man, what's wrong, and what can I do to help you get better? And some people, they're not going to let you in the door until you can write a check. So that's a benefit of emergency medicine. We do it all. Yep. I better quit. I'll talk